Good afternoon, everyone. So this talk is about the radiation dose from cardiac CT. I'm quite a fan of CT in general. That's my sort of special area, really. And just to point out, the picture behind me is one that I like to use to show off with my nuclear medicine colleagues, just to put one over them in terms of resolution and contrast and ease of scanning, that sort of thing. Okay, so that's where it's going. That's what you'll be looking at in the relatively near future. Okay, so in terms of the overview, there's be a little bit about radiation risks. Hopefully that should be revision for most of you. Some doses from medical exposures, just to put the sort of doses in context, really. An explanation of how doses are calculated in CT, because it isn't perhaps quite so straightforward as some of the other modalities or uses of radiation in medicine. Some cardiac CT doses, that's pretty obvious, I guess, from the title of the talk. And some optimization strategies, how you need to think about optimizing your radiation doses, and particularly using the new dose reduction techniques that are available to you. Okay, so I'll start with a reminder of the principles of radiation protection. And this applies to medical uses of radiation, it applies to the nuclear industry, you name it. The first is justification, okay? And I'm sure you all know about your role in that. And really that is, should we do this particular, should we use radiation in this particular case or not? Okay, and you can do that on many levels. Should we do it for, should we use radiation in medicine? Of course we should. Should we use it in cardiac CT? Yes, we should. Should we do it for this particular patient? Okay. Once you've decided that something is justified and is going to go ahead, optimization is about doing it well. Okay, so now we're going to do this particular scan. We should do it to the best of our ability and using the lowest radiation dose required to actually to gather the information we need to make a diagnosis. Okay, and then the final one is dose limits. It doesn't technically apply to medical uses, but we tend to use DRLs or diagnostic reference levels, certainly in the EU anyway, and that concept applies across the world. Am I allowed to do any Brexit jokes? No, okay. We'll see where we get to. Okay. Right, so the legal aspects, the UK approach. Now these approaches come from international either documents or treaties or guidance, and although I'll talk about the UK stuff, essentially the principles are the same wherever you are. Okay, so we have a legal requirement in the UK for patient radiation doses to be as low as reasonably achievable, or as low as reasonably practical. We can't have achievable in UK law. Okay, so reasonably practical. That doesn't mean you have to buy the latest scanner every time one's released. It's what is sensible. We also have in the UK regulations called the Ionising Radiation Medical Exposures Regulations, known as IRMA, and that basically says that all X-ray exposures must be justified and optimised. And again, that applies pretty much across the world, really, and certainly in EU legislation, and that legislation is going to be beefed up come 2018. Okay, so the requirements certainly in the EU for this are going to be increased. Okay, excuse me. Okay, so CT is relatively a high dose technique. You're probably aware of that. So in the UK, about 11% of exposures are CT. That's increasing all the time. But actually 68% of all the radiation dose in medicine comes from CT. Okay, so if we're going to optimize anything, you start with CT. Okay, some potential doses and risks from cardiac CT. The first is deterministic effects. Okay, so they're the effects that are like sunburn. Do you know what I mean? If I get my lily white skin and I go out in the sun for 15 minutes near the equator, I will burn. Okay, it's unlikely with cardiac CT that you're ever going to get to that situation. Okay, so I'm going to discount that. There are one or two groups with specific genetic conditions this applies to, but essentially, if you get into these levels, you're probably doing something wrong. Okay, so the other types of risks from radiation are stochastic effects, and these are the smoking type effects. Okay, if you smoke one cigarette, your risk of lung cancer from that one cigarette is pretty low. Okay, if you smoke 50 a day, do you know what I mean, for 30 years, your risk of lung cancer is quite high. However, once you've got lung cancer, the disease condition is the same, isn't it? Okay? So the point about that is to say that with stochastic effects, the risk is proportional to the radiation dose, okay? And that means that essentially there's no known safe dose from radiation. So we try to minimize it as much as possible, okay? So the risks are cancer and leukemia induction. Okay, if you want a number to remember in terms of risk, we talk about 5% per sievert. It rolls off the tongue. It's not that precise these days. It's slightly higher than that. But if you think about roughly 5% per sievert, that's the risk of additional lifetime risk of fatal cancer from radiation. And from cardiac CT, particularly in the early days, the doses were up to about 40 millisieverts per scan. Okay, that's relatively high now, and if you're getting doses at that level, you probably need to invest in some new technology. Okay, so if you follow those numbers through, that means an additional risk of cancer from a scan at that dose level of about 1 in 500. So this isn't trivial, okay? It's not a trivial dose from cardiac CT. Okay, so we've put some figures up here for some of the different techniques just for comparison with you, and also their cancer risks. These risks vary. They vary in time in the UK, the rest of the world, and they'll vary by centre as well. So you ought to know roughly what you're comparing against in terms of what the other techniques give you in terms of radiation exposure, so you can weigh up the risks and benefits of each technique. Okay, this is the dose distribution in CT now. So if this is our patient, so this is in the Z-axis, so up and down the patient. If I was to do one slice of 10 millimeters and actually measured the radiation dose in a line up and down right through the centre of the patient, this is roughly what the distribution would look like. People seem to think that it's, if you do a 10 mil slice, that the radiation is confined to that 10 millimeters and there's nothing outside of it. Actually, the distribution looks something like this, and it's quite complicated. And that means that the radiation dosimetry for CT is quite complicated. And really, if you're going to get involved in it, really you need a physicist to help you, I would suggest. So how do we measure doses in CT? Okay, well, firstly, the doses that people quote are the doses to these Perspex phantoms defined by the FDA, and typically for an adult patient, it's this 32 centimetre phantom. Okay, so it's 32 centimetres in diameter, 14 centimetres deep, and we basically use that as a representation of a patient. Okay, and you'll probably realise that not many patients look like that. Okay, so it's a representation. So what do we do with this particular phantom? You actually stick it in the centre of the donut here. And can you see there's an ionisation chamber that the person's just put in there? We basically stick that into each one of these holes. Okay, so they're shown here schematically, and you measure the radiation dose to that chamber in those 5 holes. So we get these measures out. Basically, we have this measure called CTDI-W, which everybody used to use. It's now really been replaced by this term here called CTDI-Vol, which everybody gets on their scanners. That's the number that you'd be interested in. And essentially, CTDI-Vol is this old unit, CTDI-W, divided by the pitch of the scanner. So that's how stretched out or how compressed the helix that the scanner scans for spiral scanning. Okay. Okay, so to work out the dose, what we do is we take a third of the dose at the centre, at this point here, and 2/3 of the dose at the periphery, and it basically gives us a weighted average of the average exposure across this disc. Okay, that's where the numbers are coming from. Okay, the next important parameter that you really need to know, and this is probably the most important one, is the dose length product. Okay, so if I multiply my CTDI value by the amount that I scan, I get a unit, a measurement called the dose length product, and that's an overall description of the dose for CT, and it's the one that relates to risk to the patient. Okay, so if you're an interventional cardiologist, you're probably used to the DAT reading from your scanners. Okay, this is the equivalent for CT. This is the number that relates to risk. Okay, so it's the average dose over the scan volume. So this is the scan volume times by the scan length. Okay, and that's dose length product, and it's proportional to risk. So if you double the DLP, you double the risk. So these values will be reported on your scanner. Most scanners will tell you now in advance what they're going to be. So they do this 2 scout scans or the 2 topograms, and then they'll tell you what you're likely to deliver. But they certainly all will give it to you afterwards, okay, in terms of some sort of output. Okay, so the next thing we do is how do we convert our DLP in terms of effective dose? So how do we get it into millisieverts? So there is a conversion factor here. So given for the chest, that's the bit we're obviously interested in, of 0.014. So you multiply your DLP by that value, and you get a very rough idea of what your dose is in millisieverts. Okay, and then you can do 5% per sievert to work out what the risk is. Okay, so how do you calculate your approximate effective dose from a particular scan? You multiply the DLP by this relevant coefficient. So where does this value come from? It comes from a publication called ICRP 103, which is basically the latest risk factors for radiation that we have. Okay, so what happens is all the data from Hiroshima and Nagasaki, all the bomb survivors and other sources as well, goes into this publication called ICRP 103, and different organs have different risks, and the idea is that you work out the weighting factors for each of these different risks. Okay, and you'll notice here that the old publication ICRP 60, the gonad risk has reduced quite considerably. Okay, not that relevant to cardiac CT. If you're scanning the gonads, you've gone down a little bit too far. Okay, you've got the breast dose, and the breast risk has increased, and obviously that's quite relevant for cardiac CT, obviously for a certain percentage of the population. And if you ever want to remember the changes, the way the physicists remember is that the balls have dropped and the breasts have been enhanced. Okay. Right. Okay. So I'm going to give you some warnings now about the use of these factors. So essentially, the sources of error in measuring these parameters are quite high. And if you start to quote effective doses or risks to more than one significant figure, you're asking for trouble. Okay. The science doesn't support that. Okay. So small individual variations in dose are not significant. So if, I don't know, let's say Siemens tell you their scanner's 5 millisieverts, okay, and Toshiba say theirs is 4.8, to me, those numbers are identical. Okay, the uncertainties in those calculations are so large, anything more than one figure basically isn't meaningless. It is meaningless. Okay, so small individual variations in dose are not meaningful. You might have 2 patients and the dose changes between scans. As long as those numbers are relatively small, the differences, it's not actually meaningful. It doesn't equate to any real risk, okay, or any change in risk. However, this unit DLP can be used for optimization. Okay, so if you do a series of patients and then do another series of patients and your DLP is halved, then the risk from the radiation will be halved. Okay, so it's very good for that's the score that you should use to work out, what your doses are and whether you've improved. Okay, and if you want to share doses with other centres, talk about your DLP. Don't worry about millisieverts. Okay, you basically use the same units that mean the same things on different scanners. Compare yourself with a sample. Get a sample of your data and a sample of their data, and if yours is lower, your doses will be lower than theirs. Okay. This is just really for your notes, just to give you some doses, typical doses from the different techniques. They vary depending on where you are in the world, what your centre's using, but find out what the figures are for your centre. But it just gives you a sense of, in millisieverts, roughly where we're talking. Okay? Right, so this data is from quite a while ago now, and this is when cardiac CT was sort of really first coming into wide use. You can see that the CT angiogram is pretty high in terms of dose. It's probably down about here now. And in terms of doses from CT, the doses are reducing really quite quickly. Doses in CT are coming down quite quickly anyway, and they certainly have done in cardiac CT. Okay, so it's a bit of a moving target. Okay, just a reminder about cancer at age of exposure. There's obviously differences in radiation sensitivity between males and females. but also children are anything up to 3 times more sensitive than the average population. Okay, so if you're scanning children, you really need to pay attention to that. The risks are about 3 times higher for the corresponding dose to the adult. Okay, but generally we're talking about that sort of region. Okay, so Einstein came up with these figures. Really, this is from the relatively early days of CT, and suggested that the risk of cancer associated with the doses from cardiac CT are about this level. So for a man, 1 in just under 2,000, and for a woman, just under just over 1 in 700. Okay, the doses have come down significantly from that value, but it's that sort of risk that you're thinking about. It's not trivial. Okay, so you've got to think about whether the patient really needs this scan or not. Okay, so how do we optimize doses in cardiac CT? We're going to use this low dose acronym that came from Professor Carl Rubottom, and it's based on this paper here, dose reduction techniques. Before and after implementation of a dose reduction program. So you've probably all heard of the protection trials that you've got to have read those studies really to do cardiac CT well. Okay, so the first is limit coverage. Okay, you have to limit the range that you're scanning. So DLP and dose is directly proportional to the scan length. So the more that you scan, obviously the higher the radiation dose. And for prospective scanning, which is the lowest dose scanning mode, each centimetre scan is about 10 chest x-rays. So you think about, you watch how accurate I am with the mouse. You're dragging out the scan range, do you know what I mean? An extra centimetre on the patient, which is probably about 10 pixels, right, is another 10 chest x-rays. You should use information from calcium scoring or even aborted scans or even previous imaging to work out the exact scan range that you need. Okay, so you need to make sure either you or the operators that are driving the scanner make use of that information. And I would suggest the radiologist or the cardiologist, certainly when you're starting out, should be in the scan room during scanning. Okay, you need to be able to discuss the cases with the operators, work out what technique you're going to choose. You need to know how successful they are at scanning. You need to know what the image quality is like when they scan using the parameters that they do. Okay. After you've had a scanner for a long time and the operators are all familiar, you may not need to do that, but certainly in the early days, you need to be in there with them. And if you're new to this technique, you need to learn as well, okay? So I would suggest you're in the scan room for the cases. You obviously need to make sure all the relevant anatomy is included. We don't want to miss anything off. Okay, so just to show you the scan range that we think you should cover, okay, and a reminder that every centimetre extra is 10 more chest x-rays. Okay, you need to optimise the MA, that's the tube current. The MA is directly related to the dose, and doubling the scanner MA doubles the dose. The MA can be reduced for small patients and should be increased for large patients. So if you look at a sample of your data, you should see a trend of increasing MA and DLP or whatever with larger patient size. If you're not getting that, you're not adjusting the factors properly. The aim is to get optimum image quality, not just as low dose as the scanner will deliver. Okay, so you've got to feedback what is your the image quality that you need. So too high an MA gives you very good image quality and very good images, but obviously there's a risk to the patient. If you give too low an MA, you get noisy images and they might not be diagnostic. Okay, so this graph really just shows you how aggressive you need to be. This is how the MAS should vary with patient size if you want to maintain constant image quality. And you can see it's a roughly exponential shape. Okay, so you should see very small doses for very small patients, and it should increase for larger patients. Okay, weight. We all know it's going up. Mine's going up. It's certainly gone up after the lunch I've had, which is very nice. However, if your patients are on the very large size, you may need to think about slightly different protocols for them to make sure that you scan them effectively. Okay. So Tara mentioned earlier about the changes in KVs and things like that. You've got to have protocols that match the weights that you're getting. Okay, so you might need different protocols for different patient sizes. On some scanners, Auto MA doesn't operate. Most of them that you buy now would have Auto MA, and it will sort this problem out for you. You need to understand what it's doing, whether it's working, check the samples of images, but once you've got that set up, it will tell you what MA to choose, but not all of them, not all scanners does it work for cardiac CT, so you need to check. Also, as the patients change in terms of size, and I'm really looking at how big they are that way, not how tall they are, you can change the KV to reduce the doses without loss of image quality. And again, there's a paper I think you've got for that, except with certain conditions that you need to exclude that for because of the effect on image quality. Okay, Sue mentioned about dose modulation. So dose modulation, this is in helical scanning when you turn the MA up and down depending on whether you're interested in the data or not. That reduces the doses by about 30%. Use it whenever you can. Use the lowest MA possible when you're not interested in the particular part of the cardiac cycle. If you're using padding, use it if it leads to higher success rates, but bear in mind that increasing the padding, the amount of padding does increase the radiation dose. Okay, obsessive heart rate control. All the centres that do this well, are obsessive about their heart rate control, aren't they? You really have to get this right. So the length of time that the heart's at rest is proportional to the heart rate, and not only does it improve image quality having a low heart rate, it also reduces the doses dramatically. And I'll show you some quite dramatic data that shows that. Okay, for faster heart rates, you might need to use more padding. If you imagine the runners jumping over the hurdles, the faster they run, do you know what I mean? The bigger time window you might need to make sure you time the jump over the hurdles correctly. Okay, so make sure you lower your heart rates. Select prospective gating. This is the lowest dose technique with your scanner, and it's a huge dose reduction when you turn it on. Most people do nearly all of their patients in this mode. Okay, depends on your patient cohort, how awkward they are, do you know what I mean, what heart rates they've got, how cooperative, all of that. But you should be doing a very high percentage of patients in this mode. You need to evaluate your doses. Okay, how many of you know what your doses from cardiac CT are? Okay, and if you don't, one person. Okay, if you don't, you should do. Okay, if you're going to get into this, you really need to know for your centre what doses you're delivering to your patients, and you also ought to know what your success rates are. How often, using the techniques that we've got, do we get a successful high quality scan? Okay, so record all your doses. There's a feature on the scanner called DICOM SR. It basically outputs all the dose and protocol information, and you can now buy dose management software that will track all this for you. So you can just say, show me the last, 6 months of cardiac CT data. So it's all captured. Okay, so keep a log of DLPs for all your cardiac CTs, along with some other information that would allow you to work out where it might be going wrong, where you need to make adjustments, and perform regular dose audits. Okay, and participate where you can in either national or international dose audits so that you know how well you're doing against your colleagues. Okay, this is some data showing the dose variations for exactly the same model of scanner. Okay, so I'm going to pick on GE, and that's not for any particular reason other than they're first. So all of these centres all have the same 64 slice GE scanner. Can you see the variation in dose from the lowest to the highest? Okay, so the patients, yes, certain patients might be a little bit larger, or their cohort might be slightly larger, but that wouldn't explain this variation. Okay, and I would suggest to you, unless you know how your doses compare with everybody else, you will probably be up here. Okay, so you need to know how well you're doing. This is some data from the BSCI and the CT user group dose survey, just to show where the pack are in terms of their doses. So I would suggest these centres here need to do something about it, and you might think that these centres down here, perhaps maybe their image quality might not be enough. Okay, so you've got to work out where you need to be. This is some data when you actually split those results down by heart rate. Okay, so below 55, around about 60-ish, 55 to 65, 150, above 65, 250. Okay. Is anybody not convinced you need to control your heart rates? Okay, control your heart rates. Okay, compare yourself with national data where it exists. I'm sure there'll be different data sets around the world. This one is in there if you want to gather it from the UK. Okay, some of the new techniques that are coming along. So there are single rotation systems. There are certainly 3 on the market now, I think. So in terms of single rotation systems, the idea is that you can scan the entire heart in one heartbeat. Okay, so as long as you get that one beat correct, that's it, you're finished. Okay, so it doesn't matter whether they've got a regular heartbeat after that. So the point about these single rotation systems is you get the whole thing in one shot, it goes beep, and you're finished. Okay, no variations in amount of contrast. Do you know what I mean? No edges between the different sections that you've scanned. Okay. All the scanners now have dynamic collimators, so as they're scanning through the patient, they chop off at either the top and the bottom the bits of radiation that you don't need, so you don't overscan the patient. That's fairly standard now. There are new techniques in terms of dual energy. You've probably heard the reps talk about these. They may be useful in some cases. I think it's mainly a research tool, and you have to remember that no matter what the manufacturers tell you, the doses are higher than the single scan equivalent. Okay, so dual energy might have its place, but bear in mind it is going to increase your doses. Sue mentioned about iterative reconstruction. They're all bringing out different software versions of this really, but essentially the more money you pay, the better the image quality or the lower the dose that you'll get. Okay, so it's got huge potential reduced doses. The images feel a little bit different if any of you have seen it. The texture's different. Now everybody thinks, well, it's different, so it's wrong. Actually, filtered back projection introduces texture and noise that isn't real in the patient either. Do you know what I mean? It's just the choice of which one is the most wrong. Okay, no imaging system perfectly represents the patient. Okay, so if you're going to try them, work out how much you're going to use, work out whether the images are diagnostic, whether they're accurate or not. Okay. Have a read of this report on Camare from Camare. It basically tells you some recommendations about how to keep your doses low in CT. It applies to CT across the board. It's got some really good tips in there, and I would suggest you implement the recommendations in that report. I'm not going to read them out, they're really for your notes there. Okay, so we move on to buying a low-dose scanner. Okay, so this is my used car salesman. Okay, I would suggest you treat all the sales team as a used car salesman, right? One lady owner, low mileage, do you know what I mean? You know the thing, right, okay. Sales teams will tell you anything because they drive a nicer car the more scanners they sell. That is their motivation. So all manufacturers will insist that their technology gives the lowest dose, because if they were to tell you theirs was the highest dose, you wouldn't buy their scanner, right? So they never tell you theirs is the worst. You should ask when you go on a site visit to see real patients being scanned at the doses that they claim. Anybody can show you lovely images on a workstation, okay? They tend to be in the 90s, osteoporotic, been on a diet for the last 20 years or whatever it is, right? So you want to see the people that are in the waiting room, you want to see them scanned on the scanner, you want to see the dose that they got, and you want to see the quality that the scanner produced, okay? So check the image quality before believing them. Don't just say, oh, it was a successful scan, see it. I would suggest you get a medical physicist on the team. I'll probably go through about 4 procurements every year for buying a scanner. Most of you will probably buy 1 scanner in your careers. Okay, so get some expert help. It really does help. Okay, so in conclusion, cardiac CT is a relatively high dose procedure. The risks are likely to be justified in most cases. Okay, however, the doses have got much lower than they were, and they will get much lower with the new technology. But really, for this technique, attention to technique is really important and will remain important for optimization, and you have to make this happen. Okay, so if I was to ask you from Sue's lecture this morning, how many of you fully understand all of those the technologies involved, right? I bet not one of you would probably volunteer that they did. Think about the operators. They're in the same boat that you are, okay? So you really have to spend time making sure that all these things are put into place properly, okay? And I can't recommend that to you strongly enough. Okay, thank you very much.